Hello viewer, welcome you all to this scientific topic about pancreatic neuroendocrine tumor as a part of module activity in the Diploma MSc course of endocrinology under the University of South Wales, United Kingdom. We all know pancreatic neuroendocrine tumor is a rare but slowly growing tumor. The incidence is slowly growing nowadays with the advancement of imaging technology, and there are different types of pancreatic neuroendocrine tumors, but the notable ones are gastrinoma, then insulinoma, glucagonoma, somatostatinoma, and VIPoma. Today's topic we will present in short about the presentation and the management of pancreatic neuroendocrine tumor. We should remember in mind that pancreatic neuroendocrine tumor can present as a sporadic in the isolated form or as a part of the components of multiple endocrine neoplasia type 1. So we should keep in mind that there could be the presentation of single disease or presentations of other disease also. Insulinoma usually presents with fasting hypoglycemia, and glucagonoma presents with GI symptoms, that is anorexia, nausea, vomiting, and also diabetes mellitus and weight loss, and a characteristic rash called necrolytic migratory erythema, which is a rash usually presents in the lower limbs and also in the trunk, and it is characteristically itchy. Gastrinoma presents with recurrent peptic ulcer disease which are resistant to treatment, and patients may present with diarrhea and also other GI symptoms like abdominal pain and hematemesis, melena. Somatostatinoma usually presents with diabetes mellitus, weight loss, and characteristic abdominal pain of cholelithiasis. Vasoactive intestinal polypeptidoma, that is VIPoma, can present with the watery diarrhea, achlorohydria, and also hypokalemia. Regarding investigations, we have common investigations we can do in our clinical settings, like a complete blood count, then ESR, liver function test, renal function test, then different hormone levels like gastrin level, fasting gastrin level, secretin level, then somatostatin level, VIP level, and also pancreatic polypeptide level. We can also do the chromogranin A level in the blood and also 24-hour urinary hydroxyindoleacetic acid. And there are some imaging modalities like we can do the DOTA gallium PET CT scan, which is more specific and sensitive, followed by the somatostatin receptor scintigraphy, and also ultrasonogram of the whole abdomen, and CT scan and MRI of the abdomen. In some of the centers there are some endoscopic ultrasound options. We can localize the pancreatic neuroendocrine tumor. And there are some provocation tests, like in gastrinoma we can do the gastrin levels after injection of secretin and also the injection of calcium. Regarding management, there are different options of management, but the surgery is the definitive and curative treatment in most of the cases. When patients are unfit for the surgery or patients are unwilling to do surgery, then we can go for the medical therapy. The aim of the medical therapy are to improve the symptoms and also to decrease the proliferations of the tumor, and it can be also used as an adjunct therapy like preoperative preparation and postoperative management the pancreatic neuroendocrine tumors. There are different surgical options that we can do, like pancreatectomy, then pancreatic resection of the tumor, that is enucleation of the tumor, then gastroduodenectomy, resections of the lymph node, resection of the liver, and even a hepatic transplantation can also be done. And regarding the medical therapy, somatostatin analogs, octreotide and lanreotide are usually used worldwide for the symptomatic benefit. We can also use the high-dose proton pump inhibitors like omeprazole and lansoprazole for the symptomatic relief of gastrinoma. Chemotherapy with ceftriaxones are usually used, and other novel therapy with everolimus and sunitinibs are used nowadays for the surgically unfit patients. And there are other options like interferon therapy and recently FDA approved peptide receptor radionuclide therapy. This is a very good choice of therapy for pancreatic neuroendocrine tumor. And follow-up is usually done by the PET scan to see the localization of the primary tumor, whether it has recurred or there is any metastasis or not. And prognosis is usually good as this is a slow growing tumor, and the patient's quality of life usually improved, and prognosis is bad in the distant metastasis, and otherwise it is good. Thank you very much, viewer, for patience hearing.